Good morning, everyone. The next topic for the day is pair exchange living donor liver transplantation. I will go through background, pair exchange LDLT, its results, challenges, and efforts to be needed to meet the challenges. LDLT is a dominant type of liver transplantation in Asian countries, including India and ILBS. Availability of a suitable live liver donor is a major limitation. ABO incompatible compatibility is main reason for donor exclusion, and ABO incompatible we should consider as a background that is a major advancement in expanding the organ pool. So just a brief about ABO incompatible, because these patients who doesn't have ABO compatible donor might be considered for ABO incompatible. So this is just a meta-analysis published in rituximab era, including almost 4,000 patients, 670 ABO incompatible and 3,200 ABO incompatible. And they found that the 1, 3, and 5-year survival and overall survival was comparable. But the major concerns are post-transplant CMV infection, biliary stricture, and antibody-mediated rejection. But what matters is the more cost and the preoperative preparation performing this type of transplant. So donor selection, if we consider it's a donor evaluation and selection, is one of the most important aspect of LDLT, because just not ABO incompatibility, there might be other factors which will preclude a donor to go ahead and to the LDLT to happen. So combining donor plus recipient related reasons, there are almost 60 to 86% prospective patients evaluated for living donor liver transplantation may be rejected. And obviously there is no scope for a marginal living donor. So just to bring our own data published from ILBS, though it's 2016, that time 460 donors were evaluated. These were ABO compatible donors in stepwise manner. And then we found that almost of them, 70% don't proceed to liver transplantation. And common donor-related reasons were donor reluctance, negative LAI, anatomical variation, inadequate remnant liver volume, unacceptable liver biopsy, and graft volume inadequacy. So, and with this background, the next step comes what determines the LDLT outcome. Obviously, it is multifactorial, recipient-related or age, made at the time of transplant, whether emergency transplant versus elective transplant. Donor-related factors are age, graft weight, steatosis, remnant liver volume. Surgical parameters which are of concern are operative time, cold ischemia time, warm ischemia time, blood loss, portal hyperperfusion, anatomical variation that demand complex reconstruction. Postoperative issues is allograft dysfunction, sepsis, surgical complications, and immunological events happening. These all are determinants of outcome of LDLT. So considering all this background, that when a pair has come for LDLT and a pair exchange LDLT is planned, so there are various options. A simple two-way exchange for an ABO compatible donor recipient pair, which is most common and straightforward and possible in India. A three-way exchange can happen between 3 sets of donor recipients who are incompatible for various reasons but are able to participate in exchange, overcoming the different incompatibilities. The 3 same donor recipient pair can continue if there is a non-directed donor, or there is a DDLT setting combined, but this is just a theoretical possibility and not practically possible in India. Other indications other than ABO incompatibility are low GIWR, small remnant volume, and anatomical variations. But I personally feel anatomical variations are in a mature transplant program is not a contraindication. So these are the pair matchings, various, I will go detail. This is simple two-way exchange. If we see that pair exchange liver transplant or a swap liver transplant, if a donor is O positive or a recipient is AB positive, it's difficult to perform and practically don't happen. So it is a donor who is either of blood group A and recipient blood group B. Then this is the two-way exchange which is possible. Next is graft size incompatibility. Even if the ABO compatibility is present, when an adult donor can donate to a pediatric patient who doesn't have ABO compatible donor, that pediatric donor can go and donate for a third patient, and the third donor donating the first patient. This is described in the Western literature, but it's limited availability because non-directed living donor is not possible in India, though happens in US, Canada, and concept of bridge donor or cadaveric donor is difficult to understand. So coming to the results of there are two actually major series published in the literature. One comes from the Asan Medical Center, published in Transplantation in 2014. They have included patients over a decade. About total 2,200 adult LDLT were performed in this period, and only 26 paired exchange donor LDLT were performed. Out of the 2 were dual graft transplant, 22 pairs were performed for ABO compatibility, 4 pairs, the other indications were either anatomical complications, complicated anatomy, or low graft weight. Elective LDLT were 22 and urgent LDLT were 4. So if we see, despite being a leading center in LDLT, the occurrence of a swab transplant per year is really less. And this just shows that the complexity, not surgical or not medical, but the logistics and getting the spare to the table is very difficult. So if we see the various, there are ABO incompatibility, but they have taken donors with blood group O, but having other indications, so that a successful LDLT cannot be performed, like low graft weight. Then a patient, it is given to a smaller recipient, and the incompatible donor of the recipient giving it to the AB donor. Then related blood group donors. Recipient, this is a dual, 2 series are dual transplant. These are for when the graft weight is not adequate for a larger recipient, but ABO compatible pair where this donor can go with and is sufficient for the ABO incompatible recipient, then swap has been performed. So this is the recipient and donor characteristics. It's the predominantly male, age is 54, primary diagnosis is viral hepatitis predominantly. They have performed 4 urgent transplant. Male score is mean around 19 and GRWR is 1.05. And this is similarly 28 donors involved in this series. 21 male, young donors, median age is 32. ABO compatibility was absent in 23, present in 5. Most of them are related, and graft type are right liver graft, left, and dual. And they have assessed the survival, patient and graft survival curves show that the overall 1 year and 5 year patient and graft survival were both 96 and 90% respectively. So coming to Indian experience, and probably as the authors have claimed, the largest series of pair exchange transplant from India, published in Transplantation 22. This is also a prospective study, included 34 swabs of 2,340 transplants performed during the same period from May 12 to April 21. It was exclusively for ABO incompatibility. ABO matching status was A to A in 17 and B to B in 17 equally. And it was performed in 4 operating rooms simultaneously by 2 independent surgical teams. So what is followed in this cohort was only AB pair exchange, like that if the recipient is blood group B and related donor is blood group A and there is an opposite pair, then only they have considered pair exchange transplant. And these are the characteristics of donor: 34, blood groups A and B, 17, females predominance, BMI acceptable, LI 9.8. Then right lobe donation, right lobe volume 775, left lobe volume 460, FLR of 38%. So it reflects that they have selected, there is no scope of marginal donors, as I said, and all are meeting standard criteria. So liver graft used were modified right lobe, left lateral graft in one, and extended right lobe, that is right with MHV in one. There is a portal vein anatomy, either type 1, mostly only one case type 3. Biliary anatomy also they have taken majority, 21 are type 1. The hospital stay of the donors was 9, and the donor morbidity only 3 patients, no donor mortality. This is again the recipient characteristics. Age 45, standard male is 21, though they had a range they have taken from 10 to 36. The CTP score is 10. Male predominance, BMI 24, and the alcoholic liver disease is the leading etiology. Hepatocellular carcinoma only 3. Graft weight is 746, range for 400 to 984, GRW of 1.04. WIT 34 minutes, cold ischemia time 98 minutes, and post-transplant ICU stay 13, and hospital stay of 20 days. But this paper is interesting in that they have compared both the recipient outcomes, because it's a natural, even a patient's fear that one of the pair will get less attention when the simultaneous 2 transplants are conducted. So they have compared the outcomes of both the recipients in the series, and there is actually, in terms of age, male square, CTP, and graft weight, GRWR, they are perfect, they are matching. There is no statistically significant difference. And if we look at the complications also, there is no significant difference in terms of bleeding, bile leak, acute rejection, hepatic artery thrombosis, hepatic vein thrombosis, sepsis, early mortality within 1 year, 1 year survival, and median follow-up was 27 months in both the groups. So this is the Kaplan-Meier curve demonstrating that there is no difference between the post-transplant survival in between the 2 groups of the recipients. So after looking at the 2 major series and both combined together is less than 100 swab transplant performed at 2 leading centers, there are certain challenges why the frequency of liver pair exchange is much less than kidney exchange, because there are legal challenges. The equality has to be looked after, because the outcome of both the pairs, it is the responsibility of the transplant team and the logistics. So considering the Human Transplant Act of India, cases of swab donation referred to under subsection 3A of section 9 of the Act shall be approved by authorization committee of hospital or district or state in which the transplantation is proposed to be done, and donation of organs shall be permissible only from near relatives of the swab recipients. Then the Transplant Act has built a safety feature, as it allows only first-degree relatives to be considered for pair exchange, and also bars the organ exchange between Indian and foreigners. And existing hospital-based government-appointed authorization committee, both transplants need to take place at same hospital. So after meeting these requirements, preoperative matching, which is difficult because the underlying principle is that neither recipient should be disadvantaged. It's the recipient-related factors, that severity of ESLD, accepting one patient who is relatively stable and one who demands or like very high MELD. So the chances of happening this transplant will be remote if one patient is sicker and the other patient is not that. Urgency, we have to take a call whether we should stick only to elective swab exchange or one patient can be urgent or yes. This is also logistically will be very demanding. Then HCC, we have to lay criteria whether both the patients HCC within UCSF, because as per our protocol, we have to do a staging laparoscopy and see whether to proceed for transplant. Then the other pair might be at disadvantage if one transplant has to be abandoned. Complexity, whether a patient with PVT, prior surgery, retransplantation, because this is linked with operative time, complexity, and more attention might be required to this pair. Then the sepsis, which is more the sick the patient, if they go in sepsis, the cancellation of this swap is more difficult, and whether another important need for renal replacement therapy. These are the parameters to be considered. It's not like absolute, and this might be considering when offer a swap transplant. Then, though the existing data says that there is no clinically no difference in the risk of right lobe donation versus left lobe donation, but again we have to consider age, donor-related factor, age, degree of steatosis, graft weight, expected GRWR, and anatomical considerations. Because the two pairs are different outside the operative room, they are at their mind, they are donating for their own patients, though the grafts are getting exchanged in the OR. But the main aim, or what is the main hurdle, is that both of them will have some doubt of suspicion whether their patient is at disadvantage or not. So another ethical consideration in paired exchange is that both donor operations should be of similar magnitude and do not pose a high risk to one of the donors. Like this may come in play when a left lateral donation versus a right lobe. On the day of operation, so as the Asian, both the papers have described, all 4 operations must be conducted on the same day. And the transplant team, 4 senior surgeons and chief, 4 anesthetists and chief, adequate supporting staff, and once the 2 transplantation surgeries are started simultaneously, their progress should be independent. It means that if one gets abandoned, you have to finish the other. It is mandatory. And though the previous papers have mentioned 4 surgeons and 4 anesthetists, but I personally feel that the patient or both the pairs will be convinced if a chief transplant surgeon or operating on the both sides, because then that one pair got a lesser attention, that doubt gets neutralized, and practically because there are so many things happening in 4 different theaters and the chief has to visit, it's not that easy because sometimes like us, the operation theaters are not available on the same floor. The timing and the progress of each operation may not be as anticipated, and adequate supporting staff. It is said that if even to perform one LDLT, we need at least 15 people in the theater. And the most important, if 2 transplants have started, practically they should progress independent, irrespective of the other. If one gets abandoned, we have to finish the other. Various time-related factors, another timer, key should be considered, or which is pressing on the surgeons or the anesthetist's mind, and as well as may determine the outcome, is that key donor operative time, donor anesthesia time, recipient anesthesia time, recipient operative time, anhepatic phase in both the recipients, cold ischemia and warm ischemia. As far as possible, we have to keep them in the normal acceptable range. So a question comes in mind that why not sequential transplant, that one pair gets transplanted today and tomorrow we will do the other. So this is reported from the United States, and where undirected, voluntary, unrelated donor has come in play, and then when the pair exchange can happen. That is not scenario in India. Sequential LP to happen on same day is difficult because one transplant takes practically at least 12 to 14 hours to finish. It's performed on different days. There is a possible risk of revocation. Liver donation is completely voluntary. Donor can withdraw their consent at last minute with no legal recourse. That we had performed a transplant today, and the next pair's transplant, if the donor withdraws his consent, there is no legal provision. We can't do anything because donation is absolutely voluntary. And because ultimate the responsibility lies with the transplant team is considered for maintaining the interest of both the pairs. So apart from these challenges, efforts needed is timely referral for liver transplant is key, because if the patient has earned his transplant, there is decompensation, then better to refer. And if he doesn't have a compatible donor, then there are 3 options. Either first evaluate his donor, whether he has a fit incompatible donor we have to see. Then he will go for a listing where there will be a definitely wait list time, and either whether suitability of ABO incompatible. That third, all these are time taking. So timely referral will go in benefit. A patient with MELD of 30 will not have that much time to think various options available. Pre-transplant evaluation should be whether there are any other factors which may preclude him or how smooth his transplant going to be and whether there is a room to optimize. That's another important thing. Donor evaluation irrespective of ABO compatibility, because now again we are coming with two options, whether we can consider pair exchange, then also whether the available donor is fit enough, and ABO incompatibility transplant, whether we can consider for. Maintaining registry of all these ABO incompatible pairs and periodic reviewing of this pair, what's happening with it. Early identification of suitable pairs, because even after identification, that matching, then counseling, then legal formalities, authorization is going to take time. And the crux is that if either of the recipient gets sick or either of the donor changes his mind over a period of time, if the waiting time is too long, then this may not happen. Then LP preoperative matching by multidisciplinary team. Along with surgeons, the anesthetist should be equally happy that the risk in both the transplant is almost more equal, or they have optimized both the recipients enough to have the expected outcome. Then early LP, once all the requirements are fulfilled, then they should be the next on the priority, because it's balancing the two pairs. One of them get either sick or withdraws the consent. Then again, all the efforts will be futile. So preparedness, that this can happen, we should always keep at the back of our mind that we have to be prepared for a swap. Then recipient selection criteria for LP, we should develop an algorithm to whom we will consider to. For example, we will not accept a male less than 30 for a LP. We will not accept a ALDL grade 4-3 PVT because the operative challenges are more. Whether we should consider an urgent or an emergency liver transplant combined with a pair. Easy to say, but practically very difficult. MELD threshold, as earlier discussed. HCC, as I discussed, our policies to perform only within UCSF. Then anticipated level of complexity in this patient. And next, we should tell whatever it may be, even for pair exchange, we have to stick to the established donor selection criteria, as there is no compromise on that. So coming to the conclusion, liver pair exchange, LDLT, is a physiological option. It is an exercise, but a patient gets a compatible, ABO compatible graft. So the outcomes should be as expected. Despite of the large experience centers, the pair exchange activity is less than 2%. At present, it is possible under existing legal requirement, and ILBS, big potential. All of us know probably the highest CLD footfall in the country or Asia, mature transplant team, and adequate infrastructure. Thank you.